Welcome, everyone. Oh. For the people who just entered, Teams automatically switch off your camera and audio, but you're more than happy to turn it back on again. We can also see who's there.
Yeah, we will wait just one more minute for people to come in, and then we will start. Okay, I think for the sake of time, I think we should get started. Maybe some more people will join in a minute. First, welcome everyone. Thanks for joining today. This Big Picture webinar. I think we have a very exciting speaker, an exciting topic today. So the speaker for today is Adam Shepherd. Adam studied in Nottingham. He got his PhD from Aston University in Birmingham, and after that he joined Nasir Rajput's group in Warwick in 2020 as a postdoctoral researcher. I think Adam mostly focuses on pathology, if I'm correct, maybe a bit of radiology, and developing deep learning AI kind of technologies. And as you are probably very much aware of, the TI group from Warwick is also a partner in Bigpicture. Today we will hear about the work that has been done in oral dysplasia. And as you may know, dysplasia grading is quite tough for pathologists. It's not very reproducible and also not always very prognostic or predictive. And Adam will show us today what they did using AI algorithms to find, say, risk score for these dysplasia. So the title for the talk is AI for predicting malignant transformation in oral epithelial dysplasia. And with that, I would like to give the floor to Adam, not before I mention that we can have questions, but please raise your hand if you have a question during the talk. So we can take questions also during the presentation, but please raise your hand and then we can keep that a bit under control. Okay, Adam, thanks for joining today, and the floor is yours.
Fantastic, thank you very much. So I'll just share my screen. So can you see that okay, sorry?
Perfect.
Brilliant. Well, thank you for that lovely introduction. So hi everyone, so my name is Adam Shepherd, and I'm delighted to be presenting my work here today. So this project isn't actually part of Bigpicture, but of course our centre collaborates as part of the Bigpicture project. And this particular piece of work is from a collaboration between the Neopath team at the University of Sheffield and with the TIA Centre at the University of Warwick, and it's supported by Cancer Research UK. I'll just get a laser pointer as well. Fantastic. So to start, I'm going to give a bit of an overview about oral cancer and oral dysplasia and discuss why early detection is particularly important. And then I'm going to discuss how we can generate some features that mimic some of the features that pathologists use in OED grading. And then I'm just going to discuss how we use these features to ultimately predict whether OED will transform to malignancy. And then I'm going to do a bit of a segue and discuss some biomarkers in cancer in general and about how we can look at these within dysplasia. And then I'll finish up. So to start, oral cancer and dysplasia. So oral cancer is one of the top 10 most common cancers worldwide, and it's actually the 14th most common in the UK. And all the statistics that I'm going to give here, I'm afraid, are for the UK. So There we are. So despite an increased amount of money that's gone towards public health campaigns across the world, public awareness of oral cancer is still pretty poor. And actually, the incidence of oral cancer is increasing every single year. And with this increased incidence of oral cancer, the mortality is also increased. And in the UK, the mortality of oral cancer is up 48% since 10 years ago, being nearly 3,000 deaths a year. And if we compare oral cancer to some of the more common types of cancer, such as colorectal cancer, breast cancer, or prostate cancer, the 10-year survival rate of oral cancer is about 18 to 57%, so it's much lower. So within the UK, globally, some of the big risk factors are smoking and also alcohol consumption. So 2/3 of cases in the UK are directly linked to smoking. And if you drink between 1.5 and 6 units per day of alcohol, then your chances of getting oral cancer actually increase by 81%. Sex is also a risk factor. 68% of cases are male, of oral cancer cases. And also 75% of cases are in people over the age of 55. And generally, when people think of mouth cancer or oral cancer, they're generally thinking of the front of the mouth, but we also have it in the oropharynx, the hypopharynx, and various other places. But of course, the tongue is actually the most common area and also has often the worst prognosis. Now, as with all cancers, early detection is really important, and prognosis is directly linked to the stage of disease in oral cancer. 2/3 of oral cancer cases are actually diagnosed in the late stage, so in stages 3 and 4. And early diagnosis drastically increases survival. So as you can see in the pie charts at the top, for the 5-year survival rate of cases that are diagnosed late is about 50%. If we instead diagnose these early, the 5-year survival rate increases to 90%, so a drastic increase in survival. And not only does early detection improve survival, it also ultimately improves quality of life. So you don't have to have such of the drastic interventions in early diagnosis as you do with late diagnosis, which can result in chewing problems and all sorts of other problems in people. So oral epithelial dysplasia, or OED, is a precursor lesion to oral cancer. And somewhere between 7 and 27% of OED cases will actually transform to cancer. And clinically, these lesions can appear as white or white-red lesions of the tongue or in the mouth in general. And in clinic, you might get a clinical diagnosis of an oral, potentially malignant disorder. But when we take a biopsy and we look at these underneath the microscope, we can get a diagnosis of oral epithelial dysplasia. A diagnosis of OED means a case is more likely to transform to malignancy. But there are no specific clinical or pathological predictors really of the risk of progression to cancer. So we can't apply a stain in OED and a part of the slide will light up and say, thus, this dysplastic case is going to become cancerous. We can't do that in OED. We have the grading system, but even that does not necessarily predict cancer progression very well. So we have 2 different grading systems. We have the WHO grading system, so the World Health Organization, and we also have the binary grading system. The binary grading system grades cases as being low risk or high risk, and the WHO grades cases as mild, moderate, or severe. And it does this based on a variety of architectural and cytological features. So your cytological features may be changes to the shape, the size, and the color of the nuclei, whereas your architectural features may be more about the stratification of the epithelium and the root pegs, how they become more drop-shaped. And the main WHO diagnostic criteria released in 2017, and there was 16 different markers here. And actually they introduced more markers in 2022, so another 11 features were introduced to this system. So as you can imagine, there is a certain level of ambiguity and subjectivity in this grading. So with the WHO grading cases mild, moderate, or severe, this is typically done in thirds. So if the architectural and the cytological features are confined to the lower third of the epithelium, then the case may be considered a mild case. If they go into the middle third of the epithelium, it might be a moderate case. And if they go into the top third, then it'd be a severe case. I've also got a cancerous case here for comparison. And I think these images quite nicely also demonstrate some of the architectural and cytological features. So in this particular image here, you'll see the nuclei are relatively, I mean, there are some differences, but they're relatively uniform. In this image here, we can see that the shape and the size of the nuclei are getting more irregular. And you can see these REAP pegs here are becoming slightly irregular in shape. But when we come to the severe case, you can see these REAP pegs are becoming really bulbous in appearance. And the nuclei are becoming very irregular shaped. And obviously, when we get to cancer, we've got invasive islands forming. So this is sort of the progression that you see. But as you can imagine, the inter and intra rate of variability in generating these grades is really, really large, and they're very subjective. And ultimately, these OED grades don't necessarily predict malignant transformation very well. So some mild cases may become cancerous, but equally, some severe cases may not. So the question we've asked is can computational pathology come to the rescue? So can we digitize these slides? Can we come up with important features? And ultimately, can we generate an AI model that will predict whether a case transforms to malignancy in a more objective and reliable manner? So these were our two objectives. The first was to develop and validate AI models that better predict malignant transformation in OED. And the second was to identify useful biomarkers to help improve pathologist grading of OED. So can we find any new features that need to be added to the Blue Book, essentially? So a bit of an overview of the pipeline that I'm presenting today, or at least the first two parts of my presentation. And this pipeline has been recently accepted at NPJ Precision Oncology. And as part of this pipeline, we take in input whole slide images. We then perform segmentation of the images. We use HOVRNet Plus to segment the intraepithelial layers, and we also segment the individual nuclei. We then generate features based off these segmentations and use these in a multi-layer perceptron to predict whether a case will transform or not transform. And this here is our OMT score, or our oral malignant transformation score. In terms of the study data for this work, we've developed our models and internally validated our models based on 270 whole slide images from Sheffield in the UK. And these were scanned across two different scanners, an Aperio and a Hamatsu scanner. And we externally validated our work on nearly, 89 whole slide images from Birmingham and Belfast in the UK, again, scanned across two different scanners. So the first step of our pipeline was to segment these whole slide images, to segment the intraepithelial layers in order to generate features for the prediction. So to segment these, we introduced HOVRNet Plus. So if you're familiar with HOVRNet, which is a state-of-the-art nuclear instance segmentation and classification pipeline, as I'm sure most people are, then HOVRNet Plus will be relatively easy to understand. So HOVRNet was released from Simon Graham and Vu Dang in our group in 2019, and it has one encoder and 3 decoder branches that do this simultaneous nuclear instance segmentation and classification. Now, we released HOVRNet Plus in 2021 as part of ICCV, and it's got one encoder, and instead of having 3 decoders, it has 4 decoders, where the 4th decoder is the layer segmentation decoder that performs a simultaneous semantic segmentation. So what we wanted to do, we wanted to train this HOVRNet Plus architecture to segment and classify nuclear instances as being epithelial nuclei or other types of nuclei. But we also wanted to segment the intraepithelial layers of the epithelium. So here we have 3 different layers of the epithelium. We have the basal layer, the epithelial layer, and the keratin layer. So in order to generate our ground truth annotations, we asked a pathologist to segment the intraepithelial layers in 68 whole slide images, which you can see here on the left. So again, these intraepithelial layers are the basal layer at the bottom, the core epithelial layer in the middle, and the keratin layer at the top. And then we then wanted to get nuclear annotations So we couldn't ask a pathologist to segment all of the individual nuclei in the whole slide images. They wouldn't have been too pleased. So instead, we generated 30 large regions of interest that were larger than this particular circle. And we asked the pathologist to simply click on each nuclei in the ROI and to assign a color to each nuclei as to whether it was an epithelial nucleus in red or another type of nucleus in orange. So of course in dysplasia, epithelial nuclei will be completely confined to the epithelium, but it's important to note the other nuclei will not necessarily be confined to the connective tissue or the other tissue. There will be some lymphocytes, for instance, within the epithelium, as is the case for intraepithelial lymphocytes. So we then got these clicks and we put them through the NuClick framework. So NuClick was developed by Navid and Mustafa in our group in 2020, and it takes in these point annotations and produces segmentation boundaries. So we use those clicks and we got nuclear instance segmentations out. We then did a slight manual refinement stage to make sure they're of a good quality. And that's how we got 30 ROIs worth of nuclear instance segmentations with the classes. Now, of course, when it comes to training our HOVRNet Plus model, we had to patch up these images into smaller patches. So we took patches at size 256 by 256 at 20x magnification for both layers and nuclei. Because there's nearly 70 whole slide images worth of layers, we ended up with 32,000 patches for the layers. And because there's only 30 ROIs worth for the nuclei, we have 2,000 patches for the nuclei. So in order to train HOVRNet Plus, we first of all just took the encoder and the layer segmentation decoder, and we trained it based on the layer patches alone, so all these 32,000 layer patches. So it would segment these intraepithelial layers. Then following this, we took all the patches that we had both nuclear and layer annotations for, so about 2,000 patches, and we took the fine-tuned encoder from the previous step and the fine-tuned layer segmentation decoder from the previous step, and we took these three branches that were pre-trained on a PanNuc, and we trained the whole network based on these patches. Excuse me. So in terms of the results, we've got our nuclear segmentation and classification results on the left from HOVRNet Plus, and we've got our epithelium segmentations on the right. So on the left, we have HOVRNet Plus compared to HOVRNet, Micronet, UNet, and DIST. So some state-of-the-art methods for nuclear instance segmentation. We then compare the dye score, so the raw nuclei versus background dye score. We have the panoptic quality, which is how well the nuclear instances have been segmented. And then we have an F1 score for classification for the other nuclei type, so the orange nuclei in these slides. And then we subclassified the epithelial nuclei into two different classes according to the layer they're in. So basal epithelial nuclei and core epithelial nuclei, so the red and the green nuclei you see in this image here. And as you can see, across the board, HOVRNet Plus generally gets the best results, or at least comparable to the best. Now in this right table, we give F1 scores or dye scores in this case for the performance of HOVRNet Plus for layer segmentation. So we have the keratin layer, so this blue layer here. We have the core epithelial layer, which is the green to blue layer here. And we have the basal layer, which is the red to the green layer here. And we also have the other tissue, which can be thought of being the rest of the tissue mask aside from the epithelium. And we can see that when comparing HOVRNet Plus to DeepLab and UNet, HOVRNet Plus gets generally the best results again across the board. So here I'll present some visualization. So this is using the TIA Viz tool as part of the TIA toolbox for visualizing these segmentations. And this was produced mostly by Mark Eastwood in our group. There we are. So here you can see in orange is the other tissue. So this is the tissue mask essentially. We have in red, we have the basal epithelium. In green, we have the core epithelium, and in blue, we have this keratin layer. And now we've zoomed in a bit more, you can also see the nuclei now, where each of the epithelial nuclei are subclassified as to which layer of the epithelium they're in. So the red's the basal, the green's core epithelial nuclei, and blue's keratin nuclei, although in theory there shouldn't really be any nuclei in the keratin layer. And we've also got these orange nuclei, which are nuclei in the other tissue, and there's also some of these orange nuclei within the epithelium, as is the case for intraepithelial sites. So going to the next stage, so using these segmentations to produce important features to ultimately predict outcome or our OMT scoring. A bit of a reminder of this pipeline. So we have input whole slide images. They go through a segmentation network, the HOVNet Plus, to segment the intraepithelial layers as well as the individual nuclei. We then generate important features based off these, which I'll talk about in the next slide. And then we train a multi-layer perceptron to predict whether a case will transform to malignancy or not, which is our OMT score. So in terms of feature generation, we tessellate up our whole slide images into smaller patches, and we look at the patches that contain epithelium alone. So in this case, these green patches, and these patches are of size 512 by 512. And per a patch within the epithelium, we then generate various nuclear features. So we generate morphological features, which are based on the different properties of nuclei within the patch. So per a nucleus, we generate 13 different properties. So the radius, the major, the minor axis, etc., eccentricity. And then we summarize that across all the nuclei in the patch. And we do that for the two nuclear types, i.e. the epithelial versus other nuclei. So we might say one of these features would be the mean radius of epithelial nuclei in the patch, for instance. So we have 13 times 4 times 2, which is 104 morphological features. And then in terms of our spatial features, these are about the environment of the nuclei in the patch, or of the environment of each nuclei in the patch, summarized anyway. So for this, we take an individual nucleus. So let's take an epithelial nucleus, and then we'll count the number of epithelial nucleus within a certain radius. And then we'll take the summary over all nuclei in the patch. And we'll do this for various different comparisons and various different radii. So 4 different radii, 4 different comparisons, 4 different summary statistics. So we have 64 spatial features, or 168 features in total. So now that we've got this n by 168 feature vector, where n is the number of epithelial patches per slide, we can then use this feature vector to train a multi-layer perceptron to predict whether a case will transform to malignancy. So we do this at the patch level, and so we predict whether each patch is from a case that will transform to malignancy, and we train this multi-layer perceptron based on an iterative draw and rank sampling scheme. So this is an IDARS sampling scheme, which and IDARS was introduced by Mohsen Bilal from our group in his Lancet Digital Health paper in 2021. And then when we go from patch level to get slide level OMT score, we simply take the average probability over all of our patches, and if they're above a certain threshold that was found in training, then a slide was determined as being as predicted to transform or not. And a few comments on here. So it's a relatively simple aggregation method. However, we did try various other attention-based MIL techniques, and we found on internal training at this validation, that this method gave us the best results. So here are some of the results here. So we have some ROC curves. On the left is our internal validation. On our right is external validation. You can see these confidence intervals because they're based on repeated cross-validation experiments. And we get AROCs of 0.77 on internal and 0.75 on external. Also got some Kaplan-Meier curves here. So again, the top is the internal testing, and the bottom is the external. On the left, we have the Kaplan-Meier curves for transformation-free survival for the WHO grade, where blue is mild, red is moderate, and green is severe. Across both of these internal and external testing, you see quite a lot of overlap in the moderate and severe grades in general, again, sort of demonstrating some of the problems with this WHO grading system. In the middle, we have this binary grading system, which grades cases as low or high risk. And we have generally pretty good separation on both internal and external testing. And when we compare our own t-score to these models, to these grades, sorry, we see that the cases that are the low risk group is the cases that our model predicted to not transform, and the high risk group is the cases that our model predicted to transform. And we see on internal testing, we have pretty good separation, and we still have good separation on external testing as well. And we've got some C indices here as well from some Cox proportional hazards models. And we see that we get a C index of 0.74 on internal testing, which is better than the binary grade. But on external testing, it drops to 0.60, but it's still certainly comparable to the binary grade. So I just want to show some quick Venn diagrams here as well for the external testing. And we see that in general, if we look at this particular Venn diagram, we see quite a high overlap between the cases that the binary grade predicts to be high risk and that the OMT score predicts as high risk, which is nice to see. However, the OMT score is a little bit more sensitive, but with a corresponding higher false alarm rate. I think for OED, it's probably more important to be sensitive because you don't want to ultimately miss a case that's going to transform to cancer. So the final stage of this particular section is feature analysis. So we wanted to see, because we've used interpretable features in our models to train our models, we wanted to see which of these features were actually useful in predicting the outcome, to see if we can actually learn anything about the problem at hand. So we looked at the true positive cases, so the cases that our model correctly predicted to transform to malignancy. And we looked at the true negative cases, so the cases that our model correctly predicted to not transform to malignancy. And we took out the top most predictive patches for the true positives and the true negatives that our model predicted. And we generated some features and did some t-tests. And some of the features some of these comparisons I want to show today are from the connective tissue and the epithelium. So when we look within the connective tissue, we can see that the nuclear counts of other nuclei are much higher in the true positives than when compared to the true negatives. So, and also if we look at the epithelium, we again see that within the epithelium, the counts of other nuclei are much higher in true positives than they are in true negatives. So what does this mean? So if we see this image on the left, we've got the epithelium here, and we've got the connective tissue here. And within this green squiggly line, within the epithelium, we can see lots of epithelial nuclei, but we can also see lots of lymphocytes. And these lymphocytes are intraepithelial lymphocytes. So what we're suggesting is that this elevated amount of other nuclei within the epithelium are actually intraepithelial lymphocytes, and they're elevated in true positives. We go to this orange squiggly line over here, we can see that the vast majority of these nuclei here are lymphocytes, not all of them, but certainly a lot of them will be. And we're suggesting here that most of these are periepithelial lymphocytes, is the term we're using. And thus, in this particular box plot, we're seeing higher amounts of PELs in true positives than when compared to true negatives. Which raises the question, are PELs and IELs new biomarkers? Because typically in cancer, increased presence of lymphocytes is thought to be a good thing. It's generally showing a robust immune response, and often cases with more lymphocytes have a better survival. But we're suggesting that maybe in dysplasia it's the other way around. Maybe having more lymphocytes present is actually saying that the case is more likely to transform to malignancy, that there's already some sort of process underway transforming this case. But I'm going to go into a bit more detail about this particular finding in a few slides. So just to finish this particular section, so I've introduced the OMT score here, and what we've seen is that we've got a comparable to pathologist performance, and we've also seen there's the potential link between an increased density of certain immune cells and malignant transformation. We've also used these sort of interpretable nuclear features to generate our predictions, and we suggest that these, increase the interpretability of our models and enable us to actually see what are being used within the model and to find these interesting differences, for instance, in the immune cells. And we've also, when we tested it, although it's not shown in these slides, we also tested it against deep features, for instance, produced by ResNet 50, and we found that our features were better on external testing. And we suggest that's because these features are in essence domain agnostic. So on this penultimate section, I want to talk about biomarker discovery. So I'm going to go in a bit of a segue for the first few slides and talk about lymphocytes in cancer, lymphocytes in breast cancer in particular, and then lymphocytes in oral cancer, and then turn back to lymphocytes in dysplasia and about a final study that we've done on these. Excuse me. So as I've already said, lymphocytes in cancer are, broadly speaking, generally thought to play a role in, are generally thought to be a positive. So specifically in breast cancer, high levels of tumor infiltrating lymphocytes, or TILs, in HER2 positive and triple negative breast cancer have been associated with better prognosis and improved response to immunotherapy. And there's been lots of work in generating TIL scores, particularly from the TILs working group. There's also been work, obviously, on the Tiger Challenge, which I want to talk about very briefly in a moment. But broadly speaking, the TILs have been found to be prognostic. We've also seen similar findings in colorectal and cervical cancer, and there's been some preliminary findings about the utility of the prognostic utility, of TILs and lymphocytes in oral cancer as well, which I'm again going to discuss in a few slides. So I'm sure I don't need to describe this particular challenge here, but so the Tiger Challenge was a good challenge, well, a great challenge that was set up in 2022 by the DAG group at Radboud and the International Immuno-Oncology Biomarking Working Group, and it had two main aims. So the first aim was to develop AI models for automated quantification of TILs, specifically in triple negative and HER2 positive breast cancer. Then they also wished to validate these AI-based TIL scores on large independent test sets. And I think this was essentially like a first step towards introducing this TIL scoring pipeline into clinical practice by validating these methods on such large scale data sets. And we actually took part in this challenge and submitted an algorithm as Team Tiger or Team Tiger back in 2022, and we presented this work in ISB, 2 or 3 weeks ago. But very briefly, the model took in an input whole slide image and tissue mask. It then went through an efficient UNet that was trained to segment the tumor and the stroma. We then generated a tumor bulk mask by doing morphological operations on this tumor stroma mask. And then ultimately, we generated a tumor-associated stroma mask by taking the overlap between the tumor bulk and the stroma mask. We then again trained an efficient UNet model to detect TILs, and we detected the TILs within this tumor-associated stroma region. And then we generated a TIL score by calculating the percentage of the tumor-associated stroma that was or had TILs present in them. So there was 2 sets of leaderboards for this challenge. There was a preliminary and a final evaluation. On preliminary testing, our model tends to do pretty well and came first in both leaderboards. But here's the results on final evaluation. So there was 2 different leaderboards. There was a segmentation and detection leaderboard, which ranked cases on how well, ranked algorithms on how well they performed both tasks. So how well they segmented the tumor and stroma. So this is the mean tumor stroma dye score, and also how well they detected TILs. So this here is the free receiver operating characteristic, which is a metric for how well the TIL detection is. You can see that our model did pretty well and came second in this leaderboard. So there's a second leaderboard too, which is based on 707 whole slide images, and you generate a TIL score for each of these whole slide images, and then these TIL scores then went through a Cox proportional hazards model to predict recurrence-free survival in these breast cancer cases. And then you got a concordance index or a C index as a result of this. And you can see that our algorithm on final testing, the C index is pretty low. It dropped to 0.59. Now, I'm not doing much work still on this particular model anymore, but Sean in our group is still working on this quite a lot with a PhD student, Jackie, and they're aiming to try and find out why the TIL score, which is doing so well for segmentation detection, is not doing quite as well for this final survival prediction. So it'll be really interesting to see why that is. But talking about TIL scoring in breast cancer, I think it's also important. It also informs us in oral cancer that potentially this is an important prognostic biomarker. And actually within our group over the last couple of years, we've Mohammed Shaban, who was a PhD student in our group, did some work looking at TILs. So there was the TILAB score, or the tumor infiltrating lymphocyte abundance score, that was released in scientific reports in 2019. And essentially, this patches up the images and gives a patch level label to each of these patches as to whether the predominant label is tumor, lymphocyte, or stroma. That then trained a CNN to predict these classes and analyze the diversity of these various these various patches across a whole slide image. And it's a bit like a Shannon diversity index they produced, but slightly different. And they call it the TIL abundance score. And they found that within oral cancer, they had good separation via this TIL abundance score. And then Shaban also continued this and created a TASL score that was published in Journal of Pathology in 2022. And it's a similar sort of idea, getting these patch level labels for the various regions. So the various stroma, tumor, lymphocyte regions, and then he generates a co-occurrence score, which is this TASL score. And they found that this TASL score was predictive of outcome. So this was for disease-free survival. There was very good separation between low and high risk groups based on this TASL score. So what I'm trying to say by discussing these previous methods is that TIL scoring has in breast cancer been found to be prognostically useful, and there's suggestions that in oral cancer it's also useful. But when we get to dysplasia, obviously there's no tumor present, but it would be interesting to see how lymphocyte scoring methods actually work. And there's no particular work really. There hasn't been much particular work on lymphocytes and dysplasia at all. And so the roles of lymphocytes in dysplasia is just not well understood. There was one piece of work by Ganot in 2002 in the British Journal of Cancer, and they found that generally in OED, so going back to oral epithelial dysplasia here, they found generally in OED there were heightened amounts of lymphocytes in more severe dysplasias, which is shown by this graph here. But this is a work based on grade. It's not based on prognosis. So it's so yes, you might have higher amounts in severe dysplasia, but that doesn't mean that all of those severe dysplasias are going to transform to malignancy. And going back to this slide that I presented about 5 minutes ago, where we said, are PELs and IELs prognostic, and are they new biomarkers? Then, so we wanted to delve into this a bit more and generate some scores for these and see if we can do something similar to what's been done in TILs in breast cancer and oral cancer. So actually, so Saad, who was a PhD student in our group, released this paper about 12 months ago. This was the prognostic utility of PELs, so these periepithelial lymphocytes, and he found that within OED, that these PELs were prognostic, that higher PEL counts were associated with malignant transformation. So it was nice to see that we found the same pattern again in my work. But in terms of intraepithelial lymphocytes, so these lymphocytes actually within the epithelium, there's been zero work whatsoever on looking at this, looking at their prognostic utility. So we asked the question, can we generate a score for IELs in OED? And will this will this be prognostic of transformation in malignant transformation in OED? So inspired by sort of the TIL scoring approaches, but also inspired by mitosis counting, we wanted to see if we can generate a similar score. So this is an image from Mustafa and our group's mitosis detection paper, where they generate hotspots and count mitoses in hotspots to generate mitotic counts and mitotic indices. So we essentially replicated these pipelines in our OED. So and this particular work is currently under review, and we've uploaded the preprint to medRxiv. So this is an overview of the pipeline. We have an input whole slide image. we trained a TransUnet model to segment the dysplasia in this whole slide image, as you can see here, by these red lines. And we then took our HovNet Plus model, which I've talked about in depth earlier, which can segment the individual epithelial nuclei and the other nuclei. And we said for these other nuclei, if they're within the epithelium, then they're most likely intraepithelial lymphocytes by definition. And so these other nuclei within the epithelium we've marked red here and called IELs. And the green nuclei are epithelial nuclei from HovNet Plus. And as I say, so inspired by sort of these TIL scoring methods, we thought, well, can we count up the IELs in this dysplastic region and come up with some scores? So we came out with an IEL index, which is the IEL count per unit of dysplasia in a slide. And we also came up with an IEL count, which is the count of IELs per 100 epithelial cells in the dysplastic area of a slide. So this is based across the whole of the slide. But then also looking at the mitotic count methods, where we look at hotspots, we took a sliding window approach and found hotspots across these slides, and found the peak areas, or the hotspots, and generated further scores. And we've called these our IPI, which is our IEL peak index. And this is the count per unit of dysplasia area in the hotspot or the peak area. And we also have this IEL peak count, which is the IEL count per 100 epithelial cells in the hotspot or this peak area. So just to summarize again, so these two scores here are based on the slide level. These two scores here are based on hotspots. And then these two scores here are based on counts per unit area. And these two scores here are counts per a number of epithelial cells, in this case 100. Again, some more visualization with TIA Viz. So here we see the HovNet Plus epithelial segmentation in green. We have the dysplasia segmented in red using the TransUnet model. Now we zoom in, we can see the epithelial. We can see the epithelial nuclei in green. And when we remove that layer, we'll see the other nuclei in red, where these red nuclei within the epithelium can be thought of as intraepithelial lymphocytes. So we then compared these IEL scores against the different grading systems again. So we've got the WHO grade in the top left. So these are Kaplan-Meier curves again. And we have various stratifications of the WHO grade here. So we've got mild versus moderate and severe combined. And we've got mild, moderate versus severe. And then we've got the binary grade. We've also got C indices and p-values from Cox proportional hazards models for each graph. On the bottom, we have our IEL index, or the II score. We have the IEL count, or the IC score. We have the IEL peak index, or the IPI, and the IEL peak count, or this IPC. And what's interesting to see here is, although these have not got quite as good separation as maybe you see in some of these grades, we are still seeing separation between cases with high amounts of IELs and cases with low amounts of IELs for all four different scoring methods. And we see that these count-based methods, so this one and this one, seem to be giving best separation, having C indices of 0.67, which is certainly comparable to that of the WHO grade. And we've got some box plots here when we've compared, if we looked at cases that transformed versus didn't transform, and we've put the different IEL scores here, so all four of the different scores. And in all four scores, we saw significantly higher scores in cases that transformed versus those that didn't transform, which was nice to see. And we also did this for grade. So here we just look at the count-based methods. So these two are the IEL count, these two are the IEL peak count. And on the left, we have the binary grade, so low versus high risk. And on the right, we have the WHO grade. And we see that for both cases, high risk cases had significantly more higher IEL scores than low risk cases. And also within the WHO grade, we see a general trend in terms of mild, moderate, and severe having increased numbers of IELs. But within this particular score, we did see a significance between mild and severe cases. So just to summarize this section, so here we've investigated the prognostic potential of IELs in OED. and we found that these count-based scores, so the IC and the IPC scores, showed relatively strong prognostic value. And when we've compared them to the binary grade, we've seen obviously that they're not quite, the C indices are a bit lower and the separation isn't quite as good. But we're not trying to predict transformation here. We're trying to see if there's any prognostic utility in actually looking at these IELs. And additionally, in the paper, I've included various multivariate analyses, which aren't maybe in these slides, but we saw that by adding in these IEL scores into the multivariate Cox proportional hazard models, we found that adding in these IEL scores to both the binary grade and the WHO grade separately actually improved the C indices, so improved the predictions. And this last piece of work about IELs has only been done on one center, so it needs further external validation. So that's one limitation here. So finally, to finish, so I hope today I've managed to describe how the prevalence of oral cancer is increasing and how it's better to detect it early, and how OMT scoring can actually help with this, because if we can predict which OED case will actually transform to malignancy, then we can treat cancer before it's even cancer, which will mean that there will be much less invasive treatment and ultimately better quality of life and survival for patients. We've released our full model inference code on GitHub, along with the model weights, which are the QR code here. And we've got the preprint up here, and I'm hoping the full paper is going to come out very soon. And I've also talked about the role of lymphocytes in both cancer and then in dysplasia, and I've also discussed how higher amounts of PELs and IELs appear to have some prognostic utility in predicting malignant transformation in OED. And to finish, so in the future, we're hoping to collect larger international and multi-centric data sets. So if anyone here wants to collaborate or has any data sets, then please feel free to get in touch. I'm also hoping to externally validate some of these IEL scores. And finally, if we want to put these algorithms into clinical practice or into the clinic, we of course need to commercialize them and to prospectively test these algorithms. So that would be the final step. Just want to acknowledge some of the people that have also worked on this on this work. So Sard from our group was a PhD student, has worked on this for a few years. Mustafa in our group has also contributed to this project. Shan has also worked on it. Fayaz and Nasir is the PI. We work very closely with the Neopath team at Sheffield, and specifically with Hanya, and also with Ali, who's a PI from Sheffield, and also with NIDA. And we've got collaborators in Queen's University in Belfast and the Enhanced group at Birmingham, who have both provided us with data and with help with the papers and analysis. And of course, everything's been funded by Cancer Research UK here. And if anyone's got any questions, I'd be pleased to take them. And thank you very much.
Thanks a lot, Adam. Great overview, great presentation. Before we go to the questions in the chat, I have one question myself. So you have this the binary grade. How did you get to the binary grading? Is this done by just one pathologist? Is this from the original report, or did you do a revision of cases?
No, it's a good question. So for the Sheffield data, it was all done by one pathologist. So actually, these are all cases that have been pulled from a digital slide archive. So we pulled all the cases, and then they were all regraded and by a single pathologist. It would have been nice to have been able to have multiple pathologists to grade them and to get some sort of inter-rater variability scores or kappa indices or something, but unfortunately we haven't done that. So yeah, all from one pathologist. Okay, thanks. We have two questions in the chat from both from Xavier. So the first one is, I just read it, morphologic spatial features. Can you stratify which are the ones or combinations that appear most predictive for the transformation prediction beside nuclear density? So I guess he asks, beyond what you have shown on the lymphocytes, do you still have
other features, unanticipated findings, and how do they compare to pathologists' traditional criteria?
No, well, thank you. That's a very great question. So, yes, in this particular presentation, I have focused on counts rather than on the various features that actually went into the multi-lab perceptron, such as the summary statistics of these features and things. But so in the paper, we've put partial density plots, which show per a case, when we vary each individual feature, we see how the prediction performance changes. And in doing so, we could find which features were found to be most to give the highest amount of signal essentially to the model. So off the top of my head, I can't quite remember what features were found to be most important, but generally we did find it was to do with spatial features in particular were found to be important, specifically to do with the sort of the interaction between these epithelial nuclei and other nuclei. We found those to be important, but also some very standard and very easily interpretable features were also found important. So the mean radius or the mean area, features like that, which are already in the Hu grading systems as like an anesonucleosis and various other grades like that. Sorry, features like that. But no, thank you for that question. I hope that's answered.
Real classical ones. I was a bit surprised, Adam. So I think let's say the cellular features you capture quite well. I don't think you really attempted to also take into account the architectural features. Like, you know, that you described it very nicely, these two thirds. So they say if the lesion is confined to the lowest third, then it's a low grade dysplasia. You didn't take that into account, I think, in your features, right?
That's correct. So yeah, it's a good question. So that was actually the first thing we did. We did the epithelial nuclei via layer instead of just using the broad epithelial nucleus. But actually, we found in the experiments that going just to using the individual nuclear labels, just one epithelial label rather than 3 epithelial labels, actually gave us better results. I think it's probably about a case of overloading in terms of features, yeah, they just didn't seem to be as prognostic, which is potentially also a sign, I suppose, about how the grading system isn't necessarily as good as it could be. And actually, in the Hu grading system, so there's been an update this year as well in January, I believe. And I think they're talking about now removing this layer segmentation completely. So it's a good question though, but we didn't find it to be useful. And we also did a piece of work on this about a year and a half ago, 2 years ago. We called it multi-scale. I think we called it multi-scale CLAM at the time, where we took architectural features such as the diameters, such as the widths of the various layers, and we found we actually used elliptical Fourier descriptors to try and what's the word I'm looking for? Try and describe the different changes to the shape of these layers, and we found them to be a sort of prognostic, but not particularly. They didn't add too much to our models and added a lot of complexity. So we ended up just reverting to using nuclear features.
Okay, makes sense. Second question from Xavier, and then we open the floor also for people to ask more questions. Xavier asks, did you investigate the proportion of Treg lymphocytes versus cytotoxic T lymphocytes in the IEL and subepithelial infiltrates in the progression toward neoplasia, so that you distinguish between different types of T cells?
That's a great question, and again, that's something that we want to do in the future. We've just got for this data set, we've just got H&E stains, so we haven't got further IHC to further distinguish these particular subtypes of lymphocytes. But that's one thing we'd definitely like to do, and I think in general in OED, some form of immunoprofiling is really, really important. So yeah, I think that's a great future suggestion.
Yeah. Okay. Okay. Any other questions from the audience? Adrian, you can unmute if you want to.
Yes. Hi, Adam. That was a wonderful talk. I really enjoyed that. I dropped in the last 10 minutes. My connectivity is really bad today, so sorry about that. I had a have a question about the HooverNet Plus. What would you attribute this jump in performance that you have from before? Because I assume that the architecture is quite standard. It's encoder decoder with skip connections, right? It's like unit style. Is it the multitask that you use there? This like additional branch, or how do you attribute that?
Yeah, no, exactly. No, thank you for the question, Adrian. So yeah, so the network is essentially exactly the same as the HoverNet network, just with one extra decoder branch. So we didn't mess around in terms of even the encoder, the feature extractor. We didn't change that. But so yes, I attribute the increase in performance or that to doing this as a multitask problem. That
awesome.
Because especially with the classification of the nuclei, I think just knowing that you're in the epithelium as opposed to in the connective tissue probably helps classification alone. That the vast majority of nuclei of epithelial nuclei will be in the epithelium, and the vast majority of the other types of nuclei won't be. So
yes, awesome. Okay, thanks for that. And one follow-up question is about the second part, which is the network which predicts the transformative prediction, right? The transformation prediction, MLP. How did you select this top predictive patches? Since you didn't use any, attention bales, multiple instance learning, and so on, so you use some sort of like traditional XAI methods. How were they selected?
Yeah, exactly. So that's another good question. So we did originally use attention-based MIL. We used CLAM. We tried all sorts of models originally this work, but actually we found that by training the model using an IDARS training strategy and simply defining a threshold and finding the threshold in internal validation, we got the best best results.
Right, yeah, because you were predicting per patch in a way, right? And then you just thresholded those. Okay, yeah.
So patch level to slide level, yeah.
Yeah, okay. Sounds good. Thanks, Adam.
Thank you.
Okay, we have a question in the chat from Sean. Please, can you confirm if you use this model in the work? Okay, then there is a link.
Thanks for the question, Sean. Some nice setting of the TIA toolbox there. So HoverNet Plus is in the TIA toolbox, and there's a notebook. It's notebook 9 on multitask segmentation, and Sean has kindly put the link to it in the chat if you want to follow it.
This feels like some illegal advertising, Adam. Do we have more questions from the audience? Okay, then I think we thank you again, Adam. Great overview and nice work. I'm curious to see the follow-up of this, and I wish everyone a great weekend.
Fantastic. Well, thank you very much for having me, and yeah, have a nice weekend, everyone.
Bye-bye.
Bye-bye.
Bye. Thank you very much, Rick.
Yeah, it was really great. Thanks a lot.
Thank you, and best of luck with the future of the project.
Yeah, thanks. Yeah, I mean, it must be always a little bit like talking to a screen is always difficult, but I think you did really well. Very interesting work. Thanks a lot.
Thanks, Rick.
All right.
See ya.
See ya. Bye-bye.